Welcome to your Intrapartum lecture, which is also known as labor and delivery. So the first thing that we want to make sure you have a deep understanding of, especially from the NCLEX perspective, is that there are stages of labor, 4 stages. And within the stages of labor, there are, in the first stage only, 3 phases. We have the latent phase, the active phase, and the transitional phase. Stage 1 goes from 0 to 10 centimeters, and the second stage of labor then comes in where we go from 10 centimeters and ends with the actual delivery of the fetus. So that second stage is our pushing, okay? The third stage is the placental stage, and that happens from the point that the fetus is born and ends when the placenta is delivered. Now that process can take different amounts of time based on how the family decided they wanted their placenta managed versus the practice preferences for the physician or advanced practice nurse. So what does that mean? What that means is that there are people that like to save the placenta for different reasons. People will use it for supplement as well as ceremony. So very important to note that as long as the patient is stable and everything is normal, then generally we can wait for the placenta to detach itself without the historic pulling. The actual sensation of pulling feels horrible to people. So it's very important that they don't pull, because even when you pull, if the placenta is not quite ready to detach, then you also will have the risk of retained placental segments. And I'm going to say that again, retain placental segments, because it's going to come back for you with postpartum hemorrhage. The 4th stage of labor is essentially that time after the delivery of the placenta, and that continues for 1 to 4 hours after delivery. So that is the point in time where we want to see hemodynamic stabilization of the mother as she is transitioning from the pregnant now back to the non-pregnant state. So this is where we need to see lochia, which is that bleeding that happens after delivery. This is where she will begin her process of diuresis so that she can get rid of the extra fluid. This is the process of, where we get breastfeeding going, because that will help to clamp down the uterus. So that entire 4th stage is the beginning of the postpartum process. Okay, so some things that you'll need to know about how you need to utilize this information for your NCLEX is that how we care for the mother in the first stage changes based on what phase she is. So in the latent phase, we're 0 to 3 centimeters. We're walking around, we're happy, we're talking, we're excited, we're in labor, or we're sick or pregnant and we're like finally, okay? And so that's generally a time where people are very active, relaxed, and happy, assuming there are no social issues. Once we get into the active phase, which, reminder, early decelerations happen at this time, that means now we're starting to get down to business. We've got an established contraction pattern, we have cervical change, and now the mother is working. So that process of working is, sitting on the ball, doing the labor dancing that they like to do, which is super fun, from YouTube videos if you ever want to look that up. This is the time where they'll begin to lose their appetite, where the bowels will open up and they'll need to use the bathroom a lot, okay? This is also the time where we are in the primipara, so that the person pregnant for the first time, we are continuing to dilate, and then once we're dilated, we begin to efface. In the multiparous mother, whose body already knows how to do it, we dilate and we efface at the same time. So that's why once you've had a baby, the 2nd and 3rd deliveries become faster and easier, because the body knows what to do. The pelvis is proven, which means a baby has put itself through the pelvis. That's the only way we prove that a baby can come out of the pelvis, is that a baby comes out of the pelvis, right? So the transitional phase is where it's not funny no more. Okay, so you'll see mothers becoming more irritable. Sometimes they'll start to feel the sensation as if they have to make a large bowel movement. Usually that's the baby's head pressing on the perineum. This is a time too where if the mother is unmedicated, there will need to be additional interventions to help them stay focused, okay? So you absolutely need to know what the interventions are based on the phases. So what when can a mother eat? Up until what time is it appropriate, right? At what point do you think a mother would ask for an epidural? Okay. Two urban legends. One is you can absolutely eat if you are not concerned for a C-section at any point in the labor. The difference is that when people are pushing, sometimes that pushing process actually puts pressure on the diaphragm up into the stomach. And so the mothers will vomit. Okay, so then there's an aspiration risk. So generally, in all honesty, most people don't want to eat. They're not hungry in their transitional phase, and they may be losing their appetite. But technically, you can feed them. But we want to try to not, simply because, you know, we have a risk of aspiration during that pushing time. For some people, pushing creates a bowel movement. For some people, pushing creates vomiting. So it's really helpful if the stomach is empty. Okay, so clear fluids and ice chips are a good recommendation at that point. How we monitor also changes based on the phases. So in the latent stage, we can probably do an NST and allow the mother to walk, or we can do Doppler intermittent monitoring. Once we get into the active phase, we can continue to do intermittent monitoring, but the frequency and timing changes. You need to memorize that. Just letting you know, you're going to have questions that are asking you how frequently you should be monitoring. In the transitional phase, and this is all talking without augmentation, no Pitocin. This is just a natural labor. And natural to me means through the vagina. The only thing that's unnatural about labor is if you have to have a C-section. Okay, so this helps break down stigma around mothers that would like to attempt to have an unmedicated birth or unmedicated delivery. The other term around natural labor is also if there's augmentation or not. Okay, so natural labor means no interventions essentially, but technically, scientifically, but we like to help mothers with psychology because there's a big thing around if they were able to do it, but they couldn't take it. Okay, so in reference to pain, every person alive that is female that can birth a baby can have a baby without pain meds. Having a baby without pain meds doesn't kill anybody. So it's very important that we help the mothers with their perspectives around pain medication. And the best time to have those conversations is in the antenatal period before labor. That's where the birth plan comes back in, or in the latent phase. Mothers start to doubt their ability once we start getting busy in the active phase, and in transition, most people don't feel like they can do it. Okay, so it's a very normal process around how the pain and frequency of the contraction happens. So with that being said, knowing the interventions for each stage, whether it's appropriate to feed your patient or not, okay? And all of that also changes if we add in Pitocin or we're adding in any risk factors, okay? The next thing to note is when do they come in even for labor? So you have to know about true versus false labor. So for example, one of the things we tell people is around the contractions. If you're having contractions, the timing of the contractions, and they're less than 5 to 6 in an hour, then you're probably not in labor yet. Okay. If you are having, greater than 5 to 6 contractions in an hour, then we do want to assess you for labor. And that's true in high risk as well as in normal labor. Okay. The truest definition of labor means cervical change. So if a patient comes in the latent phase and they're 3 centimeters, and they come into triage and we walk them for an hour, we have no change. We walk them for another hour, we have no change. The patient's having painful contractions, or maybe they're very mild contractions, but there's no cervical change happening. They are not in labor. We will send that patient home. Differently is a patient that has contractions, comes in at 3 centimeters, we send her to walk for an hour, she comes back and now she's 4 or 5 centimeters. So in that 1 hour, we have cervical change, and that means that the patient is in labor. So the definition of labor is cervical change, not just contractions, okay? So again, going back to true and false labor, we will see contractions in the back. We will see contractions down the leg. Some people will feel the contractions in their bladder. It really just depends on the woman. What we don't want to see is just tightening of the stomach, because just tightening of the stomach is the Braxton Hicks, and those are our practice contractions. Those do not make cervical change. Okay, so make sure you're clear around these 3 points. This next slide also gives you some tips. If you want to zoom in on it, you can see what's happening to the body, what to do, what you might feel, and that will help you to kind of make those connections, okay? Coaching regarding pushing based on evidence means that the mother pushing however she would like to push is best practice, okay? Some people, if they're ineffective in their pushing, so they're like, say they're screaming, right, which we call open glottis pushing, but there's no movement of the fetus. You can actually see the fetus moving, coming down. The head gets a little bit bigger on the perineum, right? So then we know that the patient's being effective in their pushing. We will coach them to do closed glottis pushing, right? We might have them do a tug of war, which we can talk about when we're in class, or I can demonstrate when we're in class. There's lots of different modes to do that. We want to coach them to push in the position that works best for them, as long as we can monitor the fetus and as long as everyone's safe. Generally, the woman's body takes over. They know what to do. It becomes an instinctual process and not a psychological process. So you keep your communication in very simple, clear, and kind terms, okay? All these things that we see on TV with people screaming at the mother or the mother screaming, that's all sensation and drama for TV, okay? So essentially, people think when they come in, their water breaks, and then 5 minutes later, they're pushing and screaming, right? That's not how that works. But interestingly, in this country, because women are not a part of each other's labor, it's not necessarily a community experience. I mean, for some cultures it is, but for most it's not. In the American psychology, most women will have had no exposure to labor or birth except for media before they are admitted to a hospital. Okay? So with that being said, please feel free to check out the examples listed below as well as in your book. Remember, all of it is testable material. The next thing that we need to make sure that you have a very good handle on is the 5 Ps, okay? So when we're talking about the labor and delivery process, we have to speak to the passageway, which is the pelvis, the birth canal, the passenger, which is the fetus and the placenta, because the placenta has to come out. Okay. And when we talk about passenger, we're also talking about the position that the fetus is in. Then we have to talk about the powers, which is uterine contractions and then maternal effort. Okay. Which is pushing. Position is literally positioned. So knowing that what position the baby's head is in, the type of pelvis the mother has, we can work with maneuvering the patient in a way that facilitates rotation and descent for the fetus. And then we have psychology. So psychology has to do with the response, emotions, previous experience, if they're prepared, their culture, their support system, if there's a partner, if there isn't a partner, was the pregnancy wanted, was it not wanted? Do they know who the father is, right? All of these things can actually affect the labor process, the labor and delivery process, okay? So the first thing we're going to start with is the passageway. And we talked about the different types of pelvic shapes and the fact that the gynecoid is the most reliable in its shape in the fetus being able to exit. So if you look at the picture, right, then you can see how that diameter changes between the ischial spines based on the shape, okay? What you can also see too is that rotation and placement of the sacrum, which also affects the diameter of the opening of the pelvis for the fetus to move through, okay? And then finally, the actual width of it, all right? So these are all the different assessment components when they do that check that we talked about in antepartum, which is the pelvimetry, okay? And that's all assessed by touch and measurement. Now, speaking to the passenger again, I want to present to you another concept, which is the actual movement of the fetus as it's exiting the pelvis. And we'll do an example of this in class, okay? So you do not have to memorize this, but an overarching concept to know how the fetus moves his head, and the fetus is moving his head to be able to get out of the pelvis, okay? So in labor, we've got the baby nice and tight. Then we move into a flexion component where the baby starts to stretch himself out. Then the baby moves his head internally. And as he's exiting, there's an extension movement, an external rotation, and then the placenta starts to separate and releases, okay? So if you wanted to memorize it for your own well-being and wanting to have a mastery for your own knowledge, the acronym that we use is every darn fool in Egypt eats raw eggs. So that's the engagement, descent, flexion, internal rotation, extension, external rotation, and then the expulsion process, okay? So don't forget, the passenger is the fetus and the placenta, okay? And its ability to rotate and move helps with the actual shape of the pelvis. So babies have instinct to rotate and move their head and their body to help themselves get out, okay? Now we also have to talk about the position. So if the baby is head down, that is called vertex. If the baby is butt down or a foot down or both feet down, then we call that breech. If the baby is side to side, like he's lying on his side, then we call that transverse. Okay. Then we also have the difference in where the baby's facing. So let's use vertex as the example, where the head is down. Okay. The baby can be facing the maternal sacrum, or the baby could be facing, for example, the maternal pubic symphysis. Okay. So that we measure based on the occiput of the head. And I will go over this with you in class. Okay. So the occiput tells us and helps us with the sutures and the fontanelles, which way the baby's head is facing. Okay, so when our baby's occiput is posterior, that is one of the hardest labors for pushing. Okay, because essentially what they say is the baby's sunny side up. And again, we'll go over this in class. Okay, again, if the baby's breech, we do absolutely do vaginal breech delivery in this country, but because we have a low threshold for litigation, then most physicians will not do a breech vaginal delivery. However, if you go to other places in the world, it is safer for a mother to deliver breech than it is for them to have a C-section, because they do things like reuse Foleys because they don't have enough of them. There are concerns with sterility and resources to make spaces sterile. And so in those cases, those physicians are very, very, very good at breech delivery. Okay. So you're aware breaches can happen via vaginal delivery. And if your patient delivers early, so the younger the baby, if the baby hasn't flipped yet, which they generally will do in the last trimester, then your baby will generally have a precipitous delivery. And that is breech. So we'll go over this in class a little bit more, where we have the baby with the pelvis, and we can give you some more examples of how that looks in the live environment. All right, so let's talk about the powers. So that's the contractions plus the mother's effort. All right, so remember, it requires the pressure of the fetal head on the cervix to create dilation. So contractions move vertically from top to bottom and from outer to inner, okay? And so that pressure of up the top of the fundus pushing down on the fetus makes that pressure on the head, and then that's where the cervical change happens. So if you do not have the baby well engaged, which means the head down lower in the pelvis, then labor will not happen, okay? The other part about it too is that the cervix has to be ready for the delivery. And so a cervix that is not ripe, which is a term that we use, and we'll talk about the Bishop's score in just a second, means that we will have to ripen the cervix, because remember, the cervix's job is to keep the baby in, okay? It should be long, it should be firm. Getting the cervix ripened and then having contractions happen means that labor is going to happen. So the next thing to be aware of is that we have to have a consistent pattern of contractions to create cervical change. So there are cases where we have a patient that has maybe one contraction every 10 minutes and that dilates her cervix. That person is gifted and should play the Powerball, because that means that in a 12-hour labor, they will have had 12 contractions and had a baby, right? Wish I was that person. However, the majority of people need a frequency, again, like we talked about, of contractions every 2 to 3 minutes. So 5 to 6 contractions minimum in an hour to be able to create that cervical change. If we don't have consistent contractions and we have a cervix that's ready for delivery, then we have to augment, which means make the body contract more. Now you can do that naturally with nipple stimulation, because what the nipples stimulation do, it releases Pitocin in the brain. So that's oxytocin in the body, right? We can encourage orgasm. We can have the patients, when the patients have orgasm, that creates contractions as well. And so those are natural methods to get oxytocin to be released in the body. If the patient does not want to do something like that, which many patients here don't, then you will see that we will add Pitocin to make the contractions, okay? Now, even with contractions, it is most helpful to have mother's effort. So not having a mother push until her cervix is fully dilated and effaced and the baby is at the appropriate station, which we like to see at a +2 or a +3, we really don't need to have a mother push, okay? If the mother is unmedicated, she will naturally push when she's ready, okay? If the mother has an epidural, then having them push when the baby is at the lowest possible point is best practice, because they get exhausted. And when a mother loses her ability to push, that's where we see a fetus being engaged in a position that creates more stress for the fetus. And so then we have to do things like use a vacuum or forceps. And so these things are not ideal. So this is why these contractions and mother's effort, where we can keep our hands out of the business and let the body do what it needs to do, is absolutely and unequivocally best practice. Again, always where there is no complication and no concerns for the fetus on the monitor. Now, positioning is magical, okay? So positioning and psychological response both fall under the category of the P's, okay, for that P specifically. So for maternal position, depending on how they're laying, then that will help the fetus with rotation and descent. Okay, so here you can see a bunch of examples of partner coached delivery, which is also known as Bradley technique. And you do need to know a little bit about Bradley and a little bit about Lamaze, okay, so that you can, because the NCLEX loves to ask questions about that, okay? So these are different positionings that help with pain management. And then if the patient is medicated with an epidural or even unmedicated, we highly encourage the use of the birthing ball for bouncing, as you can see in many of these positions, okay? And then you see the peanut ball. Now, the peanut ball is very dear to my heart because the big research study was done while I was at the bedside at Banner University Medical Center by my peers. So we were able to participate in the study. And what we found was that labor time was shortened significantly, and the time of descent was shortened significantly. Our C-section rates went down related to maternal exhaustion and to what we call fetus being asynclitic. So the term asynclitic means that the head is in an odd position within the pelvis. So this is referring to a vertex baby that might be tilted in the head, or it might be occiput posterior. Okay, I'm going to say occiput posterior again because that's something that you might see in a evaluative model for a student. Okay, so position psychology is very important, and even the psychology of the healthcare practitioner or the healthcare provider. Because if the healthcare provider is irritable and impatient, then they will impose medical intervention into the labor process, and you have to advocate for your patient and keep your patient safe in that regard. The other part of that is, and I will say it to you a million times, you do not work for the doctor. The doctor does not sign your paycheck, okay? You have a different scope and you are a team in the management of any of your patients, even in labor and delivery, OB, and outside of it. You guys are partners, okay? They provide the medical care of the patient and interventions, and you provide the nursing care and interventions, okay? So they are treating the disease process and you are treating the patient's response to the disease process. Two different scopes of practice, okay? So you will have to advocate. It's also important to know that in July is always when residents appear to the floor. And if you work at a teaching hospital, you may be a new grad and you may know more than your physician, okay? So it's very important that you work as a team, all right? And that you query and you ask questions and you discuss back and forth and you put your foot down if interventions are inappropriate. For example, the VAG exams. We talked about it. We talked about GBS and we talked about E. coli, right? So E. coli and chorioamnionitis, we recognize, is introduced usually by practitioners and poor pericare, okay? So if your resident wants to be checking the patient every 2 hours, that may not necessarily be appropriate, okay? So you will have to advocate for your patient in that regard, okay? The next thing is alternative homeopathic healthcare practices like massage therapy, acupuncture, herbal medicine, supplements, things like that are all a part of this process when it relates to dealing with the pain of induction with postpartum, right? And so what they'll do in unmedicated labors is they will use all these adjunctive therapies to facilitate the pain management process. If you get the gift of working with a doula, and I say gift because they are magnificent, if they are well trained, okay, they didn't take a couple of internet courses and now they're trying to facilitate people's labor, you know, you work with your doulas and you absolutely are practicing in the nursing scope and they are practicing as an assistant. As a birthing assistant to the family, support, additional support to the mother, and additional support to the primary partner. All right, moving forward to philosophy, partners, and patients. There is no magic ball. Often, you know, labor nurses like to have fun and kind of try to guess when the baby's going to be delivered and guess how much the baby weighs, and families like to participate in that, and they have like labor pools and weight and measurement pools where everybody's like football betting money, you know what I mean? Or they win a prize or something like that in the family. However, know that there's no magic ball, okay? We recognize that if we have a certain number of interventions and we have a certain progression of the labor, we can reasonably expect that labor or delivery will happen based on however the labor is progressing. But we really don't know. And it depends also too on what we talked about in the mother's effort and how long it takes them to get the hang of pushing. Generally, for first-time mothers, it takes a minute to figure out how to push the baby out. For mothers who have done it many times, they know exactly what to do, and there's not much that you need to coach them on, okay? So it's very important that you set up expectations with your patient. Like, be proactive in your communication. Ask them about their thoughts around labor. How long do you think this is going to take? And then you provide that education to support them in understanding what to expect. You establish trust with your patient as soon as possible, and all those things really help for a wonderful collaboration with your patient. There is absolutely and unequivocally a C-section rate associated with nurses. If you've got a nurse that is all about the interventions, all about encouraging the natural process of labor, that nurse will work hard to do everything in their power to facilitate and support not having a C-section. There are also nurses that prefer high risk and they've got to do an unmedicated labor today, and that's not their forte. And so their tendency, it's not their intention to I want to have a C-section today, so let me sabotage my patient. That's not it at all. It's just that their threshold is a little bit more limited in scope, and their skill set may be a little bit more limited in scope. So very important that we are doing everything that we can and aligning with the expectations of the patient and what it is they would like us to do for them. Okay, so that really does make a difference and help the patient out. Okay, so let's talk about labor dysfunction, which is also known as labor dystocia. Okay, that means there's a problem with one of the P's, and that requires some sort of augmentation. So we talked about the passenger and the powers and all those other things, okay? So if you look at the specific P within its own definition, then you have the interventions that go with that. For example, if we are having an issue with contractions, right? So our power, then we will, do augmentation to get Pitocin moving naturally in the body. We can also add Pitocin. We can rupture the bag of water. So that's the artificial rupture of membranes, only when appropriate. That also does help because it releases prostaglandins, and it also removes the cushion between the baby's head and the cervix. So that also helps as a intervention for labor augmentation, okay? There are some things, and so that's an example. So you need to know the P's and what the solutions are to those if there is a problem with one of those P's. So let's look now at the types of patients or the medical concerns that will cause labor to stall out, cause it to be prolonged. And then we also use the term protracted or arrested labor or descent. So the contractions peter out, the baby stops descending, and there could be reasons for that. So let's use the example of the baby not descending. If we have fetal macrosomia because we have a gestational diabetic mother, then that baby's shoulder and chest circumference is larger than the average baby. And so the baby will descend until they hit those shoulders in the pelvis. And once that happens, then there's no longer descent, okay? Or there's what we call a cephalopelvic disproportion, which means that the head is so big, and that's for our large for gestational age babies, that it doesn't match up with the opening of the pelvis, okay? So cephalopelvic disproportion, you need to know that term, all right? That is something that can happen, all right? If we talked about the example of maternal obesity, we know that our risk factors happen related to body weight as well as age, all right? If we have a pregnancy that is post-term, meaning our placenta is starting to calcify, it's not going to help the baby perfuse, the body is going to start moving, out of sync with what should have been happening in the natural progression. We've learned that male gender babies, for some reason, tend to have more labor dystocia. If you have a history of a prior shoulder dystocia, again, if you have a pelvis that's not proven, has not been proven, and then of course, if we have many babies, right? So people deliver twins vaginally all the time. That is actually not an abnormal thing. It's more normal than C-sections, I believe, at this point. So, having more babies that need to come out, that can present a problem because the uterus can be so overextended that there becomes dysfunction in its ability to contract, okay? So think about this. If you have a problem that requires a problem with labor dystocia, your body moves into a dystocia, then that also puts you at risk for certain things postpartum. Hint, hint, preview, postpartum hemorrhage, okay? So if you're in the intrapartum phase and there's first stage labor abnormalities, like maybe you've had a lot of procedures on your cervix and the cervix is simply not dilating, okay? There might be too much scar tissue. And so they can't get that to release, even with Pitocin, even with, exercises and positioning. Sometimes that cervix is not going to open. And so we just have to go ahead and do a C-section at that point. If you have a rest disorder, so for some reason the baby starts coming down, you have a prolonged second stage of labor, which means you have been pushing and pushing and pushing. Anytime you're pushing for more than an hour and a half, 2 hours, then the chances of having a C-section go up significantly. Sometimes people are pushing for 3 hours. And again, we see maternal exhaustion and then the need for assistance with expulsion, which happens with forceps and a vacuum, okay? If we have to do mid-forceps or mid-vacuum extraction, so that is, again, a problem with the expulsion process, then we're going to that's considered a dystocia. And then anytime you have an epidural, that puts you at higher risk of a labor dystocia because you're laying down, you can't walk, okay? And so, and you also can't feel when you have to push. Again, so how do you fix labor dystocia? Go back into your 5Ps to see what the solutions are, as well as the patient management in the stages and phases of labor. Okay, moving into pain relief, you went over the process of epidural placement in your lab. What we also want you to know is that in addition to things like aromatherapy and hypnotherapy and all of the natural interventions, we also have the ability to provide narcotics by IV, okay? So whenever we have narcotics administered through IV, because it's going through our IV, that means it is going into the maternal circulation, which is going to end up in the baby's circulation. So the application of narcotic analgesics means that you will need to prepare to resuscitate your baby based on the half-life of when that medication has been in the body. So for example, if you had Stadol, right, or butorphanol, and the patient suddenly delivers 30 minutes later, you're going to have a baby that's asleep because the baby is high from the narcotics. Okay, so very important to note, we don't want to give narcotics by IV if we know we are close to delivery. Epidurals can be done at any point in the delivery, and at some point in the pushing process, it doesn't even make sense to get the epidural because 2 or 3 pushes later, you're going to push the baby out. But some patients are like, I will cross my legs and you will give me my epidural now. We absolutely can do that for them. We just try to discourage it, but not because we're not willing. It's just that to, break the skin and go into the epidural space when you could push out in a couple of pushes, it just is less risk to the patient. We never want the patient to perceive that we are withholding care. And so we ask their permission, give them the information, and then proceed with their request as long as it is medically appropriate. It is not contraindicated to get an epidural and the baby's on the perineum, as long as the baby's stable. Okay. Now, if you have a narcotic analgesic administration in the IV, most of the time you've been taught in block 1 and 2 that if you have that, then you need Narcan. Narcan is not the best thing for babies. So this is going to be different than what you are learning in mental health around saving people who have had unintentional drug overdose. Babies are different. Narcan being given to a neonate can cause pulmonary edema, so much so that they removed it from the NRP algorithm. Okay. Will they give a neonate Narcan? Absolutely, but that is if every other intervention has failed to be successful. And I can tell you with the number of resuscitations I've been in my career, I have never seen Narcan given. Okay, so important to know. As long as we can breathe for the baby, we would rather leave the baby's system on their own than put them at the additional risk of the Narcan. Okay. The other thing too is there are variations of how we enter the epidural space to provide medication. So epidurals happen in the lower lumbar vertebrae, and that is essentially for numbness from the waist down. If we're having a C-section, then we're going to change the position of where we do this epidural. So the epidural happens in the epidural space and the spinal anesthesia happens in the spinal space. So they are in 2 different spaces, and the spinal provides numbness from the chest down. Okay, so very important to note that. We do not do chest down anesthesia in a patient if they are in their room. We need them to be active and moving their arms and doing all those things in labor. We will only do the epidural. Okay. The other thing to note too is that there is a natural vasodilative process that happens with this administration. So anytime we drop mother's blood pressure, what does that do to the placental pressures for the fetus? It will drop them as well. So our first intervention always after an epidural, you will rarely hear me say always, is the simultaneous assessment of fetal monitoring as well as vital signs, okay? Because we got to see where that blood pressure was. This is also a progression in your critical thinking and recognizing the blood pressure trends. So if we have, say, a patient with gestational hypertension, they hang out in the 150s over 90s. they get their epidural and suddenly they're in the 130s over 80s, you might be happy, but that placenta is not. That placenta is accustomed to perfusion in the 150s over 90s, okay? Not the 130s over 80. So you will see uteroplacental insufficiency, which means you will see lates. You can also see variables as well, but that is based on fetal movement, okay? Generally, when the medication is given in the epidural or spinal space, it does not affect the fetus the way that the narcotics given through IV does. So babies don't generally come out sleepy if they're delivered right after the epidural or the spinal, because those go into that epidural space, that spinal space, that tissue is more fatty associated. So it doesn't move through the circulation in the same way. We also have the pudental blocks, which is a block that's done on the perineum. And we do that generally, and you can see the area of coverage here. If we have to do an instrumentated delivery, you have to know that word. Instrumentated delivery means vacuum or forceps, okay? We have to use an instrument to help the baby to deliver. Historically, that creates a lot of trauma to the perineum, so we want to provide that pain control if they do not have an epidural, okay? Some people will also do pudental blocks if they're aware that they need to do an episiotomy. We avoid episiotomy as much as humanly possible because it does not heal as well, interestingly, as a tear. Tears tend to heal better than episiotomies, but we'll talk about that more in postpartum. Okay, so let's look at this related to the pain relief options. Banner University also too did a study on nitrous oxide as a vehicle for pain relief in labor, and it was a very successful study. They currently engage that practice as well. So please review very, very high level, surface level, what's happening with these and how they're timed, how does it help with labor pain, their effectiveness, and then most importantly, common side effects. Okay, so that is important for you to know. Just so that you can see, this is a big difference in OB as well. We give narcotics like they're going out of style, okay? We can give Stadol every hour. We can give dilaudid hydromorphone every hour. And remember, hydromorphone is morphine times 7, okay? And again, we only give it if we don't anticipate delivery within the next couple hours. The medication also that we choose will be based on the half-life of the medication as well. Okay, so be aware. These are general frequencies, but we use them more often in labor. So the next thing that we have to do is we have to discuss the cervix itself. So we talked about all the 5 P's of labor itself, but none of that matters if our cervix is not ready. And generally, we gather Bishop scores if we're looking to induce, okay? Because we recognize that to determine our induction method. The cervix tells us if we're going to approach by cervical ripening first, or if the cervix is appropriate to just add Pitocin, okay? We can do mechanical dilation, medication by pharmacology dilation. So we'll talk about that in just a second. So before we get to the Bishop score, we have natural signs that we're getting close to labor. These are things that does not require a physician or an intervention. So 2 of those things, or 3 of them, are lightning, energy level, and nesting. So lightning, we're not talking about the bolts in the sky, Thor's, spears, or whatever you want to call it. It is actually that the baby drops, which is counterintuitive, but the patient feels lighter because they can breathe better. So the whole time that the baby is up in the abdomen before delivery, there's that pressure on the diaphragm, okay? The second that baby moves into that engagement where they're nice and engaged in the pelvis and they're not floating away anymore, which is a term we call ballotable or ballotment, then the mother suddenly has more room to breathe, so she feels lighter, okay? So that is lightning. Generally, the energy level will increase because of the process of nesting. So this is where mother becomes super specific with whoever that primary support person is, and now we need to get the room ready Where's the crib? I need to wash all the clothes. Let's pack the bag. Okay. In my own experience, I had everybody cleaning and scrubbing my house and it was like no shred of dirt was acceptable to me in my process. And so that was my energy level nesting. I went into labor that night. So it can be a quick turnaround time between lightning and nesting. These are things that the NCLEX likes to ask about. So important for you to know. Okay. So induction and augmentation, we talked about the augmentation based on labor dystocia. And now let's talk about the induction. So why are we going to induce? You have to look up all the reasons why you want to induce. So for example, if we are past our delivery date, then we want to look at an induction. If we have encountered a problem with the fetus, a medical problem that requires immediate intervention, we will induce. Okay. So this is not term specific. It is process specific. Okay. So we use the Bishop score to determine the likelihood of successful labor induction. So we want to see the position. We want to see the consistency. Is there any effacement? Is there any dilation? And where is the fetus in relationship to the ischial spines in the pelvis itself? So high or low. Okay. So cervical position, when the cervix is intact and doing its job, it is far back and posterior. Once it moves to the mid position, then it's actually has a better chance of dilating if we apply the fetal head to it or pressure to it. When it's anterior, we're ready to go. Okay. Cervical consistency, if it's firm, it's doing its job. Medium, we're getting ready. Soft, we're ready to go. Okay. And so on and so forth. So note that we have to put all of these scores together, and that total determines the likelihood of high success versus low success. I am not going to ask you to do a Bishop score on any exam. I highly doubt, and I have not yet seen that the NCLEX will ask you to do that. What we want to know, and the number that you need to remember, is 9 to 13 or less than 5. Okay, so that's all you need to know. If it's 9 to 13, we got a good likelihood we should proceed with induction. If it is less than 5, we should not proceed with induction. And please note, as a former triage nurse, we will battle a physician over something like that. Okay, so it is slightly subjective because they're doing it by a hand exam. So it's just like a vag exam where they determine this. So it's important that, you have your own assessment for your patient. Though I must tell you, physicians don't like failed inductions. Insurance companies don't like failed inductions, and lawyers love them. So note that people do not sabotage this at all. It's just one of our measurements that is just like fetal monitoring, where there's a level of subjectivity for it and therefore a higher margin of error. All right. So let's talk about the different things that we use for augmentation. Okay. So note that Cervidil and Cytotec are prostaglandins. They cannot be given in a patient that has had a previous C-section. That is contraindicated. Okay. Prostaglandins are also associated with fever. You learned about this in your understanding of the infectious process in Block 1 and Block 2 and in your patho classes. Okay. Prostaglandins increase physical temperature. So you must be mindful if your patient is postpartum and spikes a temp. We're not going to run into the chorioamnionitis room. Okay. We're going to assess what was the method of induction, because it could just be that the patient received Cervidil or Cytotec in their delivery. Okay. Now, if we have a patient that is positive GBS, right, we're going to be thinking, infection, but we're also still going to check, was there something that could have increased prostaglandins during the labor? Okay. So Cervidil is actually this smashed tampon looking thing. We place it into the posterior fornix, which is the same place that we gather our specimens for, which is part of the lab lecture around if we're assessing for rupture of membranes. We put this little tampon-y thing in that way, and we do it manually into the posterior fornix of the vagina. We can also do Cytotec, but that pill itself, we will actually cut that pill into 4. Okay, so usually we're using 0.25 of the medication, and we also place that in the posterior fornix. What I want you to recognize here is that if we recognize tachysystole, okay, which means multiple contractions in a row without a break from our external fetal monitoring. If we have a cervidil, we can just pull it out. A cytotech dissolves immediately as you're putting it in. We just have to wait it out. Okay. The next thing that we have too is Pitocin. So you have to consider all the risks with Pitocin, oxytocin. Natural is always better, but there are the implications on the fetal monitor. It is the mismanagement of Pitocin that also causes fetal distress, and that is due to a lack of assessment or management by the nurse. So make sure that you're aware. Please recall the half-life of Pitocin, and note that we have to also, with Pitocin, if we're having an issue with the EFM, shut it off, decrease it, and then we have to wait for it to leave the system. Okay, moving on to the mechanical versions of induction and augmentation. Sometimes the patient is not a candidate for the pharmacological induction, and so we are going to do a physical induction. So the way that we do that is with a balloon, okay? It looks like a Foley catheter. We insert it and it has two balloons on it. It has a balloon on the inside and it has a balloon on the outside. We fill these balloons with fluid and then it creates mechanical pressure and it squeezes and pinches the cervix until it starts to thin out. And generally we will come in and we will tug it just a little bit. And when it releases, like very gently, then we know that our cervix is pretty much about 3 centimeters dilated, okay? So it's actual mechanical pressure pushing down on it that makes it dilate and efface. They will also do something called stripping the membranes, okay? They will put their finger into the cervix, get through the cervix into the lower uterine segment, and then they will separate the membrane, right? The bag from the tissue there. That mechanical manipulation creates prostaglandins and actually makes the cervix kind of get going. All right, so that helps as well. So here you see before the membrane sweep, we have a very well intact membrane. And then once we create that space, the body goes, oh, okay, maybe I should be in labor. And so it starts to get in there. The other thing we can do, like we talked about, is rupture the membranes, which will get rid of that little pocket of fluid, allow the baby's head to come down onto the cervix, and then creates that pressure there. We also have something called laminaria. So laminaria is actually made from seaweed, and they put the laminaria into the cervix, and through the natural vaginal secretions, it starts to absorb the water and expand and mechanically dilate the cervix. Okay, there's multiple names for laminaria. Dilayapan is one of the terms, but it's all essentially made from the same process. I mean, the same kind of materials. Okay, I think some of them use synthetic materials as well to absorb the fluids and then mechanically dilate. There's also dilation with traction. And that is when we take a regular Foley catheter, which is not this one, and we call that induction by catheter. We fill it up. We take a red robin, we fill it up, or a straight cath, and then we attach a 500 cc bag of normal saline onto it, and we pull that and hang it off of the bed. That is rough, and people generally do not do that anymore, but it is a method that they use. So it is not listed here because it is pretty barbaric. And those are things that are very uncomfortable, and it is not best practice, okay? So if you saw induction by Foley catheter somewhere, that's what they're referring to. Once the cervix is softer and more dilated, then they will move on to Pitocin or to Cytotec. All right, so let's talk about the rupture of membranes, or artificial rupture of membranes. Amniotomy is what it's called. You have to know what it's contraindicated for. Okay, so you cannot do an amniotomy, or is not recommended, for example, for HIV patients, for a patient that has an infectious disease process happening in their vagina. Now, we're not talking about GBS positive, because we know GBS is a naturally occurring bacteria in the vagina. So we're not talking about that. We're talking about, herpes with open sores, right? We're not going to do that. We're going to have a C-section in that case, okay? We also are not going to rupture the membranes if we fill the cord first, okay? It is not within our scope to rupture membranes, okay? Just so that you're aware, but sometimes it happens by accident when you're doing a cervical exam. So if you feel the cord, you need to get your hand out of that vagina and you need to call the physician for an assessment, okay? So please note and know what all your contraindications are for rupture of membranes, okay? So the first thing that you do when you rupture that membrane is you assess the fetal heart rate, okay? This applies to an AROM or an SROM because what could happen? You could have a prolapse cord. So you must find out where that fetus's heart rate is, okay? You want to note the time, the amount, the color, and if there's any odor. All right, we need to know the rupture time because we recognize that if you've been ruptured over 24 hours, your risk for infection increases significantly. Okay, we need to know how much is there. Was it a lot? Was it only a little bit? Because that will let us know if sometimes we have to come back and rupture the bag twice. Sometimes bags are very tenacious, right, in doing their job, and it takes a couple of tries to break a bag. That is not uncommon. If it is cloudy and it has an odor, it could be infection, could be chorioamnionitis. If it's yellow, greenish brown, it could be that the baby had a bowel movement and there's meconium, okay? And then of course, odor smells like rotten eggs, usually has a very distinct smell, okay? So if you wanted an acronym to help you to remember that, it is TACO, right? Because that's so appetizing, all right? Here is a picture of a cord knot, and that would cause a baby to have a bowel movement during labor, right? Because then every time we have a contraction, that knot is getting pulled, in addition to the stress of contraction generally as it exists on the baby in the fetus in the uterus. If the patient has pads, then you can see a color on there if it was meconium, okay? Now, the rupture, if it's spontaneous, can feel like a little pop, can be a gush, could be a trickle. It doesn't matter. But if the patient's reporting that, you have to immediately assess the fetal heart rate and then get your TACO, okay? So a couple of things to recognize is that once the bag of waters is broken, then that cushion is gone. So if we recognize that we have meconium, we can actually do something called an amnioinfusion, which we put in an intrauterine pressure catheter, which you learned about in lab. And we will put a bag of LR up, and then we will put the fluid back into the uterus. Okay, what that does is it kind of washes out the meconium a little bit, but that is not necessarily best practice because we do not want to be introducing intrauterine pressure catheter just for meconium. We want to only use that if we're having trouble assessing contraction frequency. Okay, if we're having repetitive variable decels, we recognize that that is because of cord compression. We can perform an amnioinfusion to assist with providing more of a cushion, put the fluid back in so that the baby can get themselves off of the cord. All right, so let's move into post-term pregnancy. So if you're past the due date, okay, we recognize that the placenta starts to calcify, okay? If we have a post-term baby, the first thing that we want to do is confirm those dates. It is usually an error in their first day of the last menstrual period. It could be an error in the ultrasound like we talked about in lab. So our first priority is to confirm, are we truly post-term, okay? Then we have something called post-term syndrome, which has very severe consequences on the fetus because the fetus now is working with a placenta that doesn't function, okay? So this is a normal placenta. On the maternal side, this is what we call the dirty Duncan. That's what's attached to the mother's uterus. And then we have the shiny Schultz, which we talked about is the side, as you can see by the cord insertion point, that connects to the baby, and the bag is around all of that. Okay, so this is it inside out, and this is it as it exits the uterus when there's delivery. So you can see how red and bright it is, and there's no black spots, it's just the shadowing of the picture. This is calcifications of the placenta. And look, the lobes aren't quite as pretty as they were because now this thing is running out. Okay, so please review post-term syndrome, okay, and what the definitions are for post-term. The next thing that we have is precipitous labor. So just like how we can have a prolonged labor due to a problem with one of our P's, we can also have someone that overshoots that process, okay? So you need to know the definition of precipitous labor and birth. So from the beginning of regular contractions to delivery is 3 hours or less, okay? Precipitous labor and birth usually occurs because the mother's body is magical, okay? Or there is some sort of trauma that the mother experienced that makes the baby come out and the placenta detach very quickly, okay? If it is naturally occurring and not related to a trauma or a disease process or something, we have to be aware that the risk of it is abruption during the actual labor before the baby leaves. So if the placenta detaches itself before the baby comes out, that is an emergency C-section. And what we would see is a fetal monitoring with a prolonged decel. Okay, you can also see the activity on the toco with the irritability of the uterus. Okay, and you can also see, so we'll stop there. Now, the risk to the mother is cervical laceration. Okay, if we look at the uterus, it is highly vascular, right? Because it's supporting a fetus, right? It has the ability to attach the placenta. There are tons of arteries that are just north of the cervix. And we'll talk about this a little bit more on postpartum. But a cervical laceration is devastating because that laceration can extend itself up into the uterus, okay? Perineal lacerations, because that mom just blows that baby right out. Those can be pretty devastating with long-term sequela. And we'll again talk about that in postpartum. We can also have fetal head trauma. Okay, so it's very important that that head comes out gently, okay? If a woman has a history of precipitous labor and birth, then we will schedule her for an induction. We also have those patients, the ones that I love the most. They would come in, they'd be like 4 centimeters, and they would tell you, it's time for me to have the baby. And then you would assess them, you would walk them, and they're like, no, I'm gonna have the baby, so you can't discharge me. You call the physician and they're like, oh yeah, we break her bag of water and she delivers within a couple of minutes. So yes, please admit her. Okay. So listen to your mother, especially if they're experienced. Okay. They will tell you what their labors are like. You must listen to your mother. Okay. Because this person obviously is defying science. Okay. So let's talk about the Friedman's curve. And this is important because it is one of the most archaic models of labor. As you can see, it was designated in 1955, and there is truth to it, but it's not black and white like this. So essentially what it's saying, if we look at this, this is the centimeters of dilation, and this is the time to get to 10 centimeters. What Friedman discovered, which is appropriate and true, is that if it is your first time having a baby, it's going to take you a lot longer to dilate. And then once you're complete, then your time to effacement and delivery comes a lot faster, okay? With experienced moms, they dilate and efface at the same exact time. And so you can see the difference is a little bit more than half in the time it takes a first-time mother to deliver versus an experienced mother to deliver. So Friedman's curve has been disproven by evidence-based practice, and a lot of obstetrical interventions have been designed around the Friedman's curve, which means every 2 hours, I should expect that my mother will dilate at least a centimeter, okay? That's not very realistic because women's bodies don't work like that. All right, so postpartum hemorrhage. This is one of the most devastating hemodynamic crises that we experience in labor. If women don't make it through a labor, it is usually due to 2 reasons, maybe 3. Postpartum hemorrhage, preeclampsia, or a trauma, okay? So the 4 T's of postpartum hemorrhage are the reasons why people will have a postpartum hemorrhage. So when you're planning your care for your patient, it's the expectation that you recognize if your patient has had a trauma, if your patient is at high risk for a postpartum hemorrhage, if your patient has a coagulopathy that we're concerned about, that automatically puts them at risk. So what are the number 1 reasons why these things happen? Tone. Okay. A boggy uterus or an atonic uterine atony, atonic uterus, is responsible for 70% of, or actually 80% now with the current data, of postpartum hemorrhage. So the way you fix that, massage the uterus. It is the easiest, most effective intervention and will save the problem, 70 to 80 times out of 100. Okay. The next thing that we have is a laceration or a rupture, which is a trauma. That's responsible for a little less. And then tissue, which is retained products. Generally, we don't see retained products because people are patient with the placenta and they allow it to detach on its own. And then we have the coagulopathy process. So you need to memorize that. Okay. The next thing that I want you to recognize is that when the placenta wall separates from the uterus, there is natural bleeding. That uterine contraction is what vasoconstricts all of those vessels that had previously supported the placenta. So we need that uterus to contract. We need that Pitocin to go. This is why we give Pitocin in all of our postpartum patients. This is why we encourage early breastfeeding, because it gets that oxytocin going. This is why we promote skin to skin care. Having the baby on top of the mother naturally releases more oxytocin. Okay. And interestingly, it is a negative feedback system, meaning and you have to go back and look at your pituitary hormone functions. Okay, you should review that anyway, because you're going to see a lot of it in renal and all of that. You know that when the uterus, the placenta leaves the body, then that makes the breast release the milk. Okay, so going back to fundamentals of hemodynamics, recognize that if we have a blood loss of 750 milliliters, okay, we'll have a normal pulse rate. We might have a normal blood pressure, but we're going to start to see a mom that's starting to get a little bit anxious. Our kidneys are still functioning. We're still breathing normal. We are hemodynamically, we're relatively stable at this point. Once we move to between 750 and 1500 milliliters out, then we start to see changes in the pulse rate. We start to see the respiratory rate go up. Okay, we start to see urine output start to decrease, and we start getting a mother that's a little bit more anxious. She doesn't really want to eat, right? So what do we have to do? Crystalloids, right? We want to fluid resuscitate the mother. Once we move past that 1500 to 2000, now we've got 30 to 40% of loss, all right? You will see hemodynamic changes. You will see a lethargic and confused mother. You will see someone that's nauseous and doesn't feel well. And this is the point where a crystalloid alone is not going to be sufficient. Okay. Once we hit 2 liters, we're in trouble. And not only are we going to see respiratory distress, very low blood pressures, lethargy, right? Now our intestines are going to stop working as well. Okay. So kidneys aren't working. Our stomach's going to stop working and we're going to have a problem. All right. So now I'm explaining this to you not because you need to memorize this chart. I need you to bring forward your understanding of hemodynamics, because this also will apply to block 4. Okay. So very, very important. And we can fix this by simply massaging the uterus. Okay. If it is uterine atony, and that is, 70 to 80 times the reason. Okay. We'll go over the medications in class because they require a little bit more conversation. So we have specific protocols around identification of the patient at risk during the antenatal or intrapartum period. Then we have what the blood loss amount is, and that drives our next set of interventions. I am not teaching you postpartum hemorrhage protocol. What I need you to know is what are all the risk factors for having a postpartum hemorrhage? How do you identify the postpartum hemorrhage? Like as in signs and symptoms like we just reviewed. Knowing that what is normal blood loss for delivery. So a normal vaginal delivery has about 500 milliliters of blood loss as the natural physiological process. If we do a C-section, we can expect about 1,000. If we have a mother with a vaginal delivery that has an EBL or estimated blood loss of 1,000, that becomes a problem. If we have it in the C-section person and it moves to 1,500, we have a problem. Okay, so we move on a protocol, and that tells us what our next steps are. Okay, so for NCLEX purposes, they're going to try to make this process very linear. Okay, but in the real world or in not in the real world. I don't want to say that because we're teaching you real world scenarios. In practice, you're calling for help as soon as you identify that your uterus that you are trying to massage is not responding, okay? Or that you've come into the room because somebody called out and said the patient doesn't look right. You lift up the blanket and you see a ton of blood on the pad. Call for help, okay? Call for help. Then you're going to massage that fundus, and then the next steps of things that they will do will happen simultaneously because you get more than one person in the room. So for example, you must start a secondary IV. You have to make sure the bladder is empty. If the bladder is full, the uterus will not contract. Okay, so these are some initial kinds of interventions that's good to memorize simply because they will be on your NCLEX. Okay, guaranteed you will see postpartum hemorrhage on your NCLEX. All right, so now you can see how the algorithm progresses. Okay, and that's it helps you to kind of see how it works. Okay, so the next thing we're going to move to is a shoulder dystocia. So shoulder dystocias happen because of a cephalopelvic disproportion. It could be related to the patient's size versus the baby size, but it could just be large for gestational age as well. Okay, so the acronym that I like to teach people is be calm. Okay, do not have the patient push. We need to lower the head of the bed. You need to memorize this. We're going to elevate the legs into McRoberts. Okay, this whole time we're calling for help. One could even argue we called for help first. Okay, we do apply suprapubic pressure, and that is above the symphysis pubis, not on the symphysis pubis. So suprapubic means above. We're going to do downward and lateral because what we're doing is getting the baby to close the diameter between their shoulders so that they can fit. Okay. We personally, as nurses, we do not enlarge anything. So we're not going to do an episiotomy, but the physician may. And then we have different other maneuvers that we will have the patient do. So head of the bed down, we will do McRoberts, we'll apply suprapubic pressure, and then we have other things that we do. Okay, so we will sweep the anterior shoulder, and then we will also do something called a Zivanelli, which is where we rotate the baby's head and we push the baby back up into the uterus and then go back for a C-section. I have to tell you, I personally have never seen a Zivanelli, okay? And I've been in a bunch of these, okay? A lot of labor nurses have. It is very, very rare for a Zivanelli to be done, but you need to know it because they want you to be aware. The other thing too is that you have to know the names of the actual interventions. So putting the mother on the hands and knees to help the baby slide back down into the pelvis and release the shoulders is called Gaskin maneuver. Okay, the posterior shoulder pressure, they call that Rubin, okay, or Wood's corkscrew. All right, so this is the picture of what it looks like. All right, and the sequela of this is that we can injure the mother's hips if we pull her hips back in McRoberts without maintaining them in the normal rotation of the body. Okay. If we are up in the stirrups for a really long time, we can increase risk for DVT, okay, because we got that pressure, the stirrup on the patient's leg. For the baby, we have the brachial plexus neuropathy because we're stretching the head and pulling on the head, and that damages the nerves that innervate from the neck to the brachial plexus. And then sometimes we have to break the baby's clavicle to make that diameter between the shoulders less. Okay, and the way that you assess that, we talked about in your first day of clinical. You would feel crackles or Rice Krispies, or what they call crepitus underneath the clavicle. You will also not see the baby moving their arm. Okay, so here is that brachial plexus issue. This is the sweeping of the anterior shoulder, and then this is the Zivanelli maneuver. Okay, you do not have to memorize the different moves of the Zivanelli because that's outside of your scope. You don't do that. You also do not sweep the anterior shoulder. That is physician and advanced practice nurse maneuvers, okay? And you absolutely never ever pull on the baby's neck and head. Okay, so moving forward into cesarean section, you have to know these 4 medications because this is the peri-op medication protocol pretty much for every surgery that exists in the medical profession. Okay, so we want to use the sodium citrate and Bicitra to decrease the acid in the stomach. We want to use the metoclopramide or Reglan to allow for gastric emptying. The ondansetron or Zofran is to decrease nausea. And then we want to give a fluid bolus for the additional blood loss that we are going to anticipate for the cesarean section. So make sure that you remember your standard operating procedure for the care of a postoperative patient. We want vitals, we want incentive spirometry, we want SCDs, everything that you learned about in block 2. And then just like in your clinical day, you got to add the dynamics of the abdominal wound with the massage and management of the fundus, as well as measuring for blood loss. Okay? Another thing to recognize with C-section is that we will have less lochia on the pad because they literally clean out the uterus after they take out the placenta. And so they ensure that there's no retained placental segments. Okay, so you won't have that shedding of that endometrium because they kind of clean it out with laps. Pretty cool stuff. That's about what you need to know about cesarean section. Okay, and you saw the video of the process of it. All right, so talking about the initial newborn transitional care, APGARs is something that you just got to play with and practice. Please go back into your preparation materials that exist in the assignments for soft chalk to make sure that you understand which is which, okay? You will be asked to calculate an APGAR score. You will be asked to calculate an APGAR score, okay? What we want to do is make sure that we're aware of how to manage all of the different transitional components of the neonate. So for example, if we know that neonates get cold, we want to get them right on top of that mama and dry them as soon as possible. If we know that they have to get used to breathing oxygen in the air environment versus their little fishy habit, then you got to make sure that they cry, okay? So keeping the head warm, making sure that they're crying, and that they're doing that transition, the APGAR score is the measurement of that process, okay? Also be aware, any high-risk labor, we could potentially see lower APGARs. And the APGAR scores advise our algorithms for resuscitation of the neonate, okay? The term on face is just like this picture, and it means the baby on the belly, on top of someone's chest. And as you can see, in this case, it's the dad. So say we're in the process of a postpartum hemorrhage, we have a baby that needs to transition, we can absolutely have dad take his shirt off and throw that baby on top of that dad and continue the neonate recovery while we're working on the mother. Obviously, this is after we ensure that we are stable, okay? So make sure that you memorize your APGARs. And we'll go over this a little bit more in class. Okay, last but not least, we will also do cord blood collection and preservation. This is very expensive, so it is usually an option for people with privilege. However, certain genetic conditions, the cord blood banking companies will donate a cord blood kit, and then the parents only have to manage the annual fees for the storage and maintenance of the cord blood. Okay, so what they will do is they will disconnect the baby. They will put in needles into the placenta and the cord, and they will collect as much cord blood as they can. It's important, and I don't think that you will be asked this, but just in case, we want to grab our cord segment to assess our gases for the labor when before we collect the blood, because then you lose your blood gas sample. Okay. All right. I think that is everything. If you have any questions, please post them in the Q&A, and I will see you in class.